to get started the next topic, our speaker is here and our moderators are here. So let's get started with the next talk. Thank you.
Thank you. Thank you.
Thank you, Dr. Bilani. Very nice of you to. Yeah.
Thank you, Dr. Bilani. Thank you, Angela, for that very interesting and informative presentation. And I also want to thank all the members who already joined. And we have an excellent presentation coming up. Today, the World Heart Day, September 29th, which started on 2012 to reduce the disease burden of cardiovascular disease across the world. So there's a lot of research and education being done in this process to educate the members and community to get better with their cardiovascular outcomes. And actually, my good friend, Dr. Brahma Sharma, is going to moderate the session. He's a very passionate, not only a good cardiologist, but he's an all-round Renaissance man. He talks about meditation, he talks about spirituality. He knows more about brain than I do as a psychiatrist. And it's my distinct pleasure to invite Dr. Brahma Sharma, who is a associate professor at UPMC and also affiliated with VA hospitals here. He's been a friend of mine since 1989, since we both started in Pittsburgh here. So welcome, Dr. Sharma. Please take over and you can start the introductions as well as moderation of the session. Thank you.
Thank you, Ravi. Am I audible?
Yes.
Yes, you are.
Okay, thank you, Ravi. Today is a special day, World Heart Day, as you already mentioned. Cardiovascular disease, with or without COVID, is still the leading cause of death all around the world. We South Asians account only for about 20% of the world problem population, but account for about 60% of the global cardiovascular burden. On the home front here in the United States, we are about 4 million. And yet we have 2 to 4 times the risk of a heart attack. And it's a pressing issue for us and is a silent epidemic in parallel with the COVID. For the last 50 years, we have been trying to figure out what it is that is causing this unusual epidemic in South Asians living here or in India. We have come with a lot of theories about metabolic syndrome, dyslipidemia, genetics, inflammation, or a combination. The conventional risk factors do not explain this. Something much more is going. And we still don't know exactly. This is like an enigma as to what exactly is happening, but it is happening. And that has become not only a public health issue, but also a disparity issue. Disparity and inequity is a buzzword nowadays. If there is any description of a perfect disparity, that's what it is. We are a small percentage, about 2%, yet we bear the burden of heart attacks and sudden death out of proportion in this country. Not only that, if you look at the NIH trials, they include Caucasians, they include Hispanics, they include East Asians, but I don't see much about South Asians, whether it's a epidemiology, whether it's a biobank, whether it's genomics. And it's very hard to predict when we don't even know how do we calculate our risk factors. We know the Framingham risk factor, the Framingham was a different population, does not apply to us. We try to extrapolate it, but we don't have the authentic data. And that's where Dr. Alka Konaya, Professor Alka Konaya, who is here with us today from University of San Francisco, she is the leading figure, the face of the South Asian heart disease. I don't know, you read the New York Times article in February 2020. She was on the front page. So we are very happy to have her, honored to have her, give us insight into this epidemic for South Asians today from her own authentic original work. Now, everybody knows Dr. Kanaya, but just for briefly, she has done her medical school from UCSF, a residency from UCSF, and she's currently a professor in internal medicine and endocrinology. She's also leading efforts about equity, inclusion, and South Asian heart disease. So there cannot be a better person, a better speaker for us today to enlighten us on this pressing issue, which is there all the times with or without COVID. Dr. Kanaya, this is all yours.
Thank you very much for your warm welcome, and I really appreciate the introduction, but I have to say that this is a team effort, and what we've learned has
is the tip of the iceberg, and we hope that we have many more years to continue learning about South Asian heart health with a prospective cohort study. So I've been asked to kind of give you a whirlwind tour of what we've learned so far in Masala, and really to focus in on, heart health and spend some more time on coronary artery calcium. So I'm going to kind of split my talk into different sections. But let's, why do a study like Masala? That's because we have data like this from the United States, from the UK, from Singapore, from South Africa, from almost any diaspora country. This new data comes from Northern California, Kaiser, where I'm located. And they looked at the 10-year incidence of heart disease by different race ethnic groups. And this is fairly recent data. And what you can see here in blue bars are overall men and women together. Orange bars are men and gray bars are women. And South Asians here on the far left have the highest incidence of heart disease compared to East Asians, other Asians, Blacks, Hispanic, white, and other groups. And the big question is why? And I think thanks to Dr. Sharma for setting this up is, we have so much left to learn because the conventional risk factors don't really explain all of this risk. So that was the main reason we started the Masala study. And the aims, Masala stands for Mediators of Atherosclerosis in South Asians Living in America. And the aims were to really establish a Framingham-like study in the US. But of course, this was based on a very small R01 grant that we got from the NIH, and nothing like what Framingham has had for the last 60 years, over $300 million of a commitment to Framingham. This was based on a very small study where we wanted to establish a prospective community-based cohort of South Asians in the US to determine what factors are associated with subclinical atherosclerosis. Now, we know that that's just the beginning point of cardiovascular disease. It's the first manifestation, but there may not be any signs, so it's subclinical atherosclerosis. And we took a very broad perspective, socio-ecological perspective, looking at traditional risk factors as well as sociocultural, behavioral, and novel risk factors. So we're doing a multi-level type of analysis. And we wanted to compare the prevalence of risk factors and atherosclerosis in South Asians directly to 4 race ethnic groups that are represented in the ongoing MESA study, the multi-ethnic study of atherosclerosis. And we want to investigate factors that are associated with developing cardiovascular disease. Really, the goal is to develop Framingham type of equations for prognosis of who is at highest risk and what can we do to prevent this risk. So we designed the study to be parallel to MESA, but we wanted to start with the age being slightly younger because we know South Asians develop diabetes, heart disease at least 10 years earlier in age. So we started with age 40 to 84 years old for an inclusion criteria for the study. We did a random sampling of 900 people. That's all we could do with the small grant we had. And we used the same methods as MESA because we wanted to compare apples to apples. So they had no existing cardiovascular disease to be included in the study. Anyone who had a cath was excluded, anyone with atrial fibrillation, anyone who's had any kind of surgery, stents on their heart or arteries was excluded because we wanted people without any existing cardiovascular disease. So you can already tell that when we are including people with no existing cardiovascular disease at the age of 40 to 84, this is a relatively healthy population because they've lived to 84 and not developed cardiovascular disease yet, right? But that's the same inclusion that MESA did. So we were trying to be, apples to apples so we can compare the different groups in MESA to Masala. So if anything, I want you to keep this in mind that this is, the data I'm showing you with our Masala participants represents the healthiest outlook on South Asians without, cardiovascular disease yet. So we included 900 South Asians at 2 sites, my university in San Francisco and Northwestern University with my co-PI, Dr. Nami Kandula. And we did a pilot study in San Francisco in 2006 that really gave us really good preliminary data to propose this larger study. And we started the large study now 11 years ago. It's hard to believe we've been following participants for 11 years. And we completed the second exam a few years ago in 2018. MESA is a much larger study, included 6,500 people, 4 different race ethnic groups: whites, blacks, Latinos, and Chinese Americans. Has 6 different sites around the United States. The only overlapping site was Northwestern University between our 2 studies. They started 10 years before Masala. So they were doing exam 5 in MESA when we started Masala, and we try to compare as we go with the same age groups. So here's what we've accomplished so far in Masala. The first exam was completed in 2013. We brought people in to do a fasting blood test, a glucose tolerance test, coronary calcium CT scan, carotid ultrasound, and EKG, looking for subclinical atherosclerosis. Of course, we measured all the usual traditional risk factors, and we saved a lot of blood, a lot of urine, a lot of DNA, a lot of RNA on everybody. And then Dr. Kandula, my co-PI, got a very nice grant to look at social networks of the participants in our study, because we know that there's a lot of influence of your social networks on your health, and wanted to map that really well. Then we brought everyone back for a second exam in 2016, where we repeated some of the same tests because we wanted to look at change in glucose tolerance in the CT coronary calcium score. And we were lucky to get a philanthropic gift, and we're able to include 258 new participants, trying to diversify the South Asians that we have in Masala, because we have mostly Asian Indians. We wanted to include more Pakistanis, more Sri Lankans, etc. And this year in June, we got some very good news that NIH funded us for a third clinical exam that we're about to start in 2 weeks at UCSF. And this exam is going to focus on heart function. We're going to bring everybody back and do echocardiogram and other tests of vascular stiffness and endothelial function. And we also got new funding from another NIH institute to expand our cohort, recognizing that, you can only do so much with a cohort of 1,000 people. And they see that there is so much diversity in South Asians. We've been able to show them that with data from around the world, that not all South Asians have the same risk factors. So in this new wave B, we are going to be enrolling 1,150 new participants. Half are Bangladeshi and half will be Pakistani. So that will really bring us up with enough numbers of Indians, Bangladeshi, and Pakistani to look at differences among the 3 subgroups. And we're effectively doubling the size of the cohort to 2,300. So we're in the middle of launching both of these studies now. So it's a very exciting time for us. So in the remaining 35 minutes, I want to go through some of our, the details we've learned about the Masala participants in the study so far. Diet, what's the influence on diet on cardiometabolic health, acculturation. I want to spend some time on body composition and diabetes, and then really, spend 15 or so minutes talking about coronary artery calcium and some of the novel measures we've been doing in Masala. So in our cohort of now 1,164 people, we have 98% are immigrants to the United States. A majority, 83%, were born in India. And you can see very few were born in other South Asian countries, and 2% were born here in the US. And that's, of course, immigration patterns. We expect there to be very few people age 40 to 84 who would qualify to be in Masala, who were born in the US. But you can see why we really need to add more numbers of people from Pakistan and Bangladesh. Those are the second 2 most populous South Asian groups in the US in terms of the US Census data. So, given another 3 or 4 years, we will have robust enough data to be able to actually compare people immigrating from these 3 countries. So how about how long have people been in the US? People in our cohort, on average, have lived about 28 years of life in the United States, but it's a nice bell-shaped distribution. So there's some very recent immigrants, and there's some people who've been here, most of their life. So the average percent time of life in the US is about 50%. And as we know by the US Census data, that South Asians are the most highly educated of all groups in the United States, especially the Asian Indians. And you can see here for the men in Masala, very few, only 5% had a high school degree or less, and almost 64 had greater than a bachelor's degree. 47% of women likewise had greater than a bachelor's degree, and family income tracks with the high education as well. So this is very comparable to the US Census data. So even though Masala includes people who don't have a history of heart disease or cardiovascular disease already, in terms of the demographic factors, this really does look like a lot of the Asian Indian data in the US. So what about their other risk factors and lifestyle and behaviors? So in this slide, I'm showing you the South Asians in Masala, excluding those between age 40 and 45, because the MESA groups are between age 45 and 84. So comparing apples to apples here, and you can see that MESA had a lot more in terms of numbers of whites and blacks, but we are fairly similar in terms of the number of Latinos and Chinese. So in terms of smoking, the Chinese and the South Asians in Masala were least likely to smoke compared to the other three groups. Alcohol use was also fairly modest in the Masala participants, higher in the other three groups in MESA, but much lower in the Chinese. Exercise, however, was pretty abysmal in the South Asians. Now, this is using a questionnaire where we ask about all sorts of activities, leisure time activities, activities at work, activities like walking, yoga, dancing, all sorts of activities. And even though this is a very highly educated, affluent group, you can see the level of exercise done in the South Asians in Masala was the lowest compared to all of the groups in MESA. So low-hanging fruit, a modifiable risk factor. We have a lot of work to do. So let's talk about diet, because everybody has their theories about diet. And so we wanted to really spend some time and energy in trying to measure diet as carefully as possible. As you all know, the diets around the various parts of India are so different. And then you add in different parts of South Asia, even more diverse. So it was a real challenge to think, how can we measure diet in immigrants from different parts of South Asia who are still eating a lot of South Asian foods, but also maybe eating some American foods? So we were lucky to be able to partner with our colleagues in Canada who've done the SHARE study, and they developed a very nice food frequency questionnaire in South Asians in Canada. And so we used that food frequency questionnaire because they actually have, different types of curries and preparations that are North Indian, South Indian, Bangladeshi, Pakistani. And so people can, report what types of foods they've been eating. This food frequency questionnaire is not perfect. None of them are, but I think it's as good as you're going to get for any kind of dietary questionnaire in South Asians. And so what we've done with this food frequency questionnaire that we've measured many different types of foods, we did a kind of a data analysis where we grouped people into different types of dietary patterns. And we found there's three major dietary patterns. And about a third of the cohort was eating mostly an animal protein or Western diet, shown here, showing you pictures of, I guess this is chicken tikka kebab. And then in the middle here, a third were eating more of a traditional South Asian diet that was rich with fried snacks, sweets, and high-fat dairy products. So you can see a lot of desserts as well as snacks here. And a third were eating a much more prudent diet that was fruits, vegetables, nuts, and legumes. Now you look at this and say, well, this is non-veg, and these two are veg. Turns out that there are some non-veg food items in these two groups. About 50% of people eating this middle type of diet were totally vegetarian, lifelong vegetarian. And about 50% of people in this diet were also lifelong vegetarians, but the other 50% were eating some meats, but it just wasn't a major component of the diet. And what we found when we just correlate these dietary patterns is that people eating the Western animal protein-based diet had a higher weight and a bigger waist circumference. And the people in the middle group, the traditional South Asian diet, had higher blood pressure, lower HDL cholesterol, higher levels of insulin resistance compared to people eating the more prudent diet. So this is great. It's cross-sectional data. And it kind of, makes sense to me in terms of not all, vegetarian diets are healthy for sure. There can be lots of, problems with high carb and high saturated fat that people may be getting in this diet. So what we wanted to do was be able to look at our dietary data in a prospective way and really tease apart plant-based diets. So what we've done is partnered with some researchers at Harvard to look at the different types of plant-based diets that people are eating. And we classified a healthy plant-based diet, whole grains, fruits, vegetables, herbs, nuts and legumes, tea and coffee, and less healthy plant-based foods that are more refined grains, fruit juices, starchy vegetables like potatoes, deep fried snacks, coconut, very controversial, but more or less belongs in the less healthy category based on recent data, sweets and desserts, and also sugar sweetened beverages. And what we wanted to do is look at people in the healthy plant-based diet and those in the less healthy to see who develops diabetes in the 5 years when we brought them back for exam 2. And here you can see the odds ratios. Now the black dot shows you people eating any plant-based diet, and then we tease it apart with healthy plant-based diet versus less healthy. And you can see in terms of who has a fatty liver, those with the healthy plant-based diet were much less likely, lower odds of having a fatty liver, whereas those with an unhealthy, there was no significant association. And then we looked at who developed diabetes 5 years later, and people in the healthy plant-based diet were much less likely to develop diabetes. So some prospective associations. And this is after adjusting for other risk factors like waist circumference and BMI and hypertension, et cetera, et cetera. So this is really interesting. So here's some good data that, really eating and getting our patients to conform to more of a healthy plant-based diet may be associated with lower risk of developing diabetes in the future, something that we've all intuitively known, but now there's some hard data. So let's talk about acculturation. This is something that I am very interested in because I don't think we do a good enough job at understanding this in most studies. Most studies have only used how long you've lived in the US to say how acculturated someone is. But in Masala, we actually used 9 different items here that we thought about and wanted to really, think about different aspects of acculturation. These are some of the ways we measured it. And again, using these data and analysis techniques, we made groups of people based on how acculturated they are. And what we found was that acculturation is associated with atherosclerosis. So here is an ultrasound of a carotid artery of one of our participants, and we looked at carotid intima media thickness. That's the thickness of the carotid wall between the pink line and the blue line. That's the near wall, and here's the far wall of the common carotid, or actually this was, the common carotid artery. And what we used was one of our measures of acculturation, and we found that people in the moderate category of acculturation who had both some American beliefs as well as some South Asian beliefs had lower carotid intima media thickness than those with strong South Asian beliefs. And that's really interesting because this was after adjusting for the traditional risk factors as well as for diet and physical activity and cholesterol medication use, independent of everything. Having a bicultural, both adopting some, cultural beliefs of the US and retaining some from South Asia was more protective in terms of the thickness of the carotid wall. And this is important because we know that carotid intima media thickness, the larger the thickness, the greater the risk of developing stroke in the future. So as I was saying, we've used our acculturation measures to categorize people into 3 categories based on all of this data. And what we have developed is the 3 categories are, one is a separation class, where people here are more traditional in their South Asian beliefs, and about a quarter of our 23% of our cohort are in the separation class, very, very traditional South Asian in their beliefs. About half, 54%, are bicultural in that integration class, what I was talking about with the last data analysis. So about half are both adopting some American beliefs and lifestyle behaviors, as well as keeping some South Asian. And another quarter, about 23%, exactly the same proportion, are in an assimilation class. That means that they're much more American in their beliefs and behaviors, and not very South Asian at all. And so when we looked at what tracks with these three categories, we found that people in the separation class had more depression symptoms. And that does make sense if you think about it, because they're isolated, maybe more from the community around them, and they're feeling like a little bit left out because they're separate from the rest of the population. Whereas what we found is people in the assimilation class and the integration class, both of these groups had lower cardiometabolic risk. They had less visceral fat, lower glucose tolerance numbers on glucose tolerance testing, better cholesterol values, and that was especially so in women. So this is interesting because if you compare South Asian immigrants in the US to other immigrant groups like Japanese, Latinos, Mexicans, that you find that the more assimilated or the more American someone becomes in their beliefs and their behaviors, the worse their cardiometabolic health, the more obesity, the more diabetes, the more heart disease. We are actually finding something opposite here, which goes to tell me that there must be something that is not so good about being very, traditional in beliefs if these people here have lower cardiometabolic risk. And so there's a lot we still need to learn about culture and how culture tracks with behaviors and other stressors that may be causing higher cardiometabolic risk. Let's move on to obesity and to ectopic fat, one of my favorite topics. So as you know, the WHO has recommended that we use Asian cut points to categorize BMI and risk of overweight and obesity in Asian groups. And we aren't using this clinically. I hope you in practice are using the correct BMI cut points for normal weight for any Asian group should be up to 23. Then 23 to 27.5 are overweight, and greater than or equal to 27.5 is obese. And we do use those when we categorize masala South Asians. And when we looked at the different groups of normal weight, overweight, and obese, and here we're showing you masala in red, the prevalence of normal weight was about 25%. Sort of in the middle compared to the other groups of MESA. You can see the Chinese had a lot more people in the normal weight, and we used the Asian BMI cut points for Chinese and South Asians, and we use the standard BMI cut points for normal weight for the other groups. And when you look at overweight, the South Asians are just as overweight as everybody else, about 45% overweight. When you look at obese, right in the middle, there's just as much obesity prevalence in the South Asians, so about 30% obese. The Chinese are the least obese, but and the African Americans are the most obese. And here you go, so South Asians are not a not obese population. There's a fair amount of obesity if you use the correct BMI cut points. So what we were interested in looking at is this normal weight group, that even in the normal weight group, these are the people who are being given a pass when they see their doctors, when they go to the clinic. Oh, your BMI is in a normal weight. You're great. Keep doing what you're doing. Are they really that healthy? So in this analysis here, we looked at who is metabolically abnormal, and this is based on the metabolic syndrome criteria: fasting glucose elevation, high triglycerides, low HDL, and high blood pressure. And we looked at who was metabolically normal. And here you can see the South Asians have the highest proportion of metabolic abnormality, even those in the normal weight group. Now, this was BMI less than 23. And you can see the proportions are about the same for South Asians as other groups when you get to the overweight and obese. But this is striking because there is, some metabolic abnormality in all of the groups, even in the normal weight, but the South Asians have the most metabolic abnormalities. And so when we look at this, we wanted to really look at what BMI is equivalent to an overweight BMI in whites for South Asians. And here it's a kind of a complicated graph, but I'm going to try to show this to you, is the BMI of 25 in whites over here is roughly equivalent to a BMI in terms of risk of 19.6 in South Asians. So that's saying that a white person who is just at the overweight criteria has as many metabolic risk factors as a South Asian who has a normal BMI of 19.6. And the other groups also, fall lower, much lower than the whites of 25. So if this tells you anything as a practicing internist, this tells me BMI is useless, worthless for any kind of screening of South Asians, because you can have a completely normal BMI and have a lot of metabolic abnormalities. So do not rely on the BMI in terms of who you screen for diabetes, for heart disease, blood pressure, anything. And we've known this, at least for the last 20 years, that there is this paradox of BMI and weight. So Dr. Yudkin, a European colleague, has a BMI of 22.3, and Dr. Yajnik from Pune, a good colleague of mine, has a similar BMI. But if you measure their body fat, you can see the South Asian gentleman has a much higher body fat based on DEXA scans compared to the European. So we've known this, and we wanted to do a closer, deeper dive of this in masala. So we wanted to look at hidden stores of fat, fat in the muscle, fat in the liver, fat around the visceral organs, so visceral adipose tissue, and fat around the heart. And we've used CT scan technology to do this. So we cross-section through the abdomen here. And what we do is we use software to code the subcutaneous fat in green, the visceral fat in light blue, the intermuscular fat in light blue here, and the liver fat. We can't use the same technology. We have to use a different method of measuring liver fat attenuation. And so the higher the attenuation, the less the fat there is in the liver. And so what we found when we compare the masala participants to MESA is the South Asians store fat in all of the wrong places. So we look at the yellow bar for South Asians here, and the other bars are the MESA groups. Visceral fat is high, but after adjusting for age and other metabolic risk factors, it's about as high as for whites. So visceral fat is not the big outlier here. It is higher than what we see in Chinese, Africans, and Latinos. But what is the big outlier is more muscle fat in the South Asians and a lot more liver fat. So this is an inverse variable, but the amount of fat in the liver was the greatest in the South Asians compared to the other four groups in MESA, and the amount of lean muscle mass was the lowest too. So there is definitely a difference here in where fat is being stored. And this is, I think, part of the reason that there's acceleration in insulin resistance and diabetes risk, and most likely really has a big role to play in accelerated atherosclerosis and heart disease. So what about diabetes prevalence? 26% had diabetes based on fasting glucose and 2-hour glucose tolerance test, or that they were already on a diabetic medication. A third were pre-diabetic, and 42% had normal glucose tolerance. How does this compare to the MESA groups? Quite interestingly, big differences. So in the men in masala, shown in the first bar, almost 30% had diabetes, 37 pre-diabetes in orange, much higher than the other groups, the whites, the African Americans, Latinos, and Chinese. Look at the women. The prevalence of diabetes was 15% in our masala women compared to 30% in men. So half as many South Asian women have diabetes compared to men. This is really interesting to me, because look at the men-women difference in all the groups. Women have lower prevalence of diabetes compared to men, regardless of what race ethnic group. And this is true in India. This is true in every country around the world now. But this is really striking that the women in Masala are so much lower than the men, but they are still higher than other groups of women. Unfortunately, African-American women had slightly higher rates than South Asian women. So when we put all of our data together and when we fully adjust the prevalence of diabetes in Masala was 26.7%, much higher than all of the 4 other groups in MESA. And this is after adjusting for many, many, many metabolic risk factors as well as other confounders for diabetes. So we also looked at people who didn't have diabetes and found that people in Masala had much higher levels of insulin resistance measured by HOMA compared to the other groups in MESA, and much lower pancreatic beta cell function compared to the other groups in Masala, in MESA. And this is, what is setting up South Asians to kind of go quickly towards diabetes is spend very little time in the pre-diabetes range because people travel so quickly and become diabetic because their pancreas really is not able to keep up with the needs of insulin resistance. Hypertension prevalence was fairly high, about 46% had hypertension based on blood pressure 140/90 or higher, or using a blood pressure medication. The African Americans had significantly higher blood pressure prevalence, high blood pressure prevalence compared to South Asians. The other 3 groups were lower. Cholesterol comparisons using the standard cholesterol, there was really nothing too striking. Total cholesterol was not that elevated compared to other groups. It was even lower in Blacks. LDL was fairly similar, and this is taking out anyone using any statins or fibrates or any kind of cholesterol lowering. So these are people not on any cholesterol medications. LDL is no different. HDL may be slightly higher than some groups like Latinos and Chinese, and maybe about the same as whites and Blacks. Triglycerides were kind of in the middle, not that much higher. So this is what we hear, that, South Asians have very low HDL and very high triglycerides. Not in Masala. And in our study, they're pretty average in terms of overall, cholesterol panel. Of course, this is just your standard lipids. We've done lipidomics and metabolomics, and we've looked at subfractions. And yes, there are some differences. I'm also going to show you some other biomarkers here that may be interesting to some. So when we looked at other, risk factors, both that are clinically available now that can be measured, as well as some that are more research biomarkers, we see that South Asians are very different. You see asterisks everywhere because South Asians are extremely different than the other groups. The Lp(a) levels are higher, but not as high as Blacks. Blacks are double the Lp(a) of South Asians. HSCRP is not that much higher. It's actually lowest in the South Asians compared to the other groups. Chinese are even lower. Tumor necrosis factor alpha is another inflammatory factor, was actually lowest in the South Asians. Adiponectin, this is a hormone secreted by fat cells, was lowest in the South Asians, which is predictable because of the high rates of diabetes. Higher levels are more protective. Resistin, another adipokine, was highest in the South Asian. So yes, there are some big differences, but not all bad in terms of the inflammatory factors. They look better in the Masala groups compared, and this is using the same exact blood tests, same methods in the same research labs that was done with MESA. So let's just talk about coronary artery calcium, do a time check. Yes, I have 15 minutes or so to talk to you about this. Now, I think you're all probably very familiar with CAC and how we measure CAC, and this is a cross section through the heart, and calcium is seen in the arteries, and it can be scored, and you get a CAC score. And what we're doing when we measure CAC is we're looking at calcified plaque, which is very early in the process of an MI as the plaque ruptures and you get thrombus and full occlusion of the artery with myocardial infarction. So it's a precursor of incident coronary heart disease, but it is also, something that we're interested in and looking at compared to other groups. And what we found here in terms of the median CAC scores in the men, comparing the Masala men in red to the other groups in MESA was as men age, CAC goes up for all groups. But the whites and the South Asians, there's no significant difference between the numbers, even in the 70s and 80s. These are actually very similar in their overall median CAC scores. But the other three groups in MESA, the African Americans, Chinese, and Latinos had much lower CAC levels, even at age 80. Their median CAC was only about 100, whereas for the whites and South Asians, it was more like 300. For women, you can see the y-axis is totally different. Women have much less CAC, even at age 80 compared to men. And here's where you see kind of a little bit of a difference here, where there's no difference in the CAC scores for women until age 60. And then the curves start to split a little. But the South Asian women are somewhat intermediate to the white women and the other groups. So, the hypothesis going into Masala was that because there's so much incident cardiovascular disease in South Asians seen around the world, that we expected CAC to be much higher in the South Asians. But what we found was, after you adjust for all the traditional risk factors, the whites and South Asians, basically, there's no difference in the level of CAC for any age group. But the other three groups have much lower CAC burden compared to whites and South Asians. So what about change in CAC? So when we brought people back 5 years later, we looked at CAC again. And so we were interested in who had a 0 CAC score and developed new incident CAC, as well as who had some positive CAC in the baseline exam and then came back and actually developed more progression of CAC. Are there differences in these incidence rates? And what we found was incidence of any new CAC was, again, the same kind of story. The white men and the Masala South Asian men had the same incidence of new CAC. The other three groups were lower. No difference in the women. Pretty much all of the different groups of women had the same amount of incidence of new CAC. Very interesting that it's tracking well. How about progression of CAC? Progression, this is a very crowded table, but I want you to focus in on the red rows here. This is looking at men. This is their CAC change. So if they changed their CAC scores by 10 to 99 between in 5 years, or between 100 to 199, the rate of change in these two categories of CAC was highest in the South Asian men compared to the other men. All other groups had lower change in CAC in this moderate range of change. And that is quite impressive. And that was very different than all the other groups, even more so than the whites. So South Asian men had faster change in CAC than men of all other groups. After we adjust for the traditional risk factors, diabetes, hypertension, lipids, age, smoking, there was no difference again between the white and South Asian men, and there was no difference among all of the women. So, this tells me that CAC is an important risk factor where we've seen that the correlates of CAC are smoking, diabetes, high blood pressure. They're associated with both development of new CAC and progression of CAC. But there's a lot of interest in CAC because we have not done the final analysis to look at CAC predicting cardiovascular disease. But in early analysis, it looks like CAC will be an independent risk factor for those who develop heart disease. Some other interesting things that we're doing now are some advanced plaque analysis for the cardiologists in the group here. We're looking at the volume and density of each plaque and in which segments of the coronary tree people develop plaque and how fast that plaque progresses in 5 years. And what we found is the RCA has the greatest plaque progression in 5 years, and the left main has the greatest increase in plaque density. So interesting, and that smokers had the greatest change in CAC volume overall. And what we found here is very interesting, that those who exercise more and those who had higher Lp(a) levels and higher insulin levels were the most likely to have greater change in CAC density. And having a dense CAC or dense plaque is actually a very good thing because it protects from rupture. And so this is a very interesting finding because MESA has seen that having more exercise stabilizes plaque and makes plaque more dense. But we found that not only exercise, but higher Lp(a) levels, which is supposed to be adverse, and higher insulin, supposed to be adverse. Both of them were actually associated with higher density of CAC. Super interesting, very early data. We're about to publish that data now. So we've presented it at the AHA meeting already as an abstract. So we're doing some new analyses looking at the left anterior descending artery and looking at the size of the artery, the cross-sectional area compared to other ethnic groups. So what we're trying to do in Masala is, develop a cohort that's big enough that we follow long enough that we can look at who has cardiac events, cardiovascular events, and then what factors predict people who go on to have events. Now, with a small cohort of 1,000 people, even following them for 10 years, you're going to have limited number of events. And so we haven't been able to develop the Framingham type models that were based on 5,000 people being followed for 20 years. So what we found so far, just early analyses, is that the same traditional risk factors seem to be important, looking at who develops incident CVD, but we're finding some very novel risk factors like CAC, volume, and density. So the higher the density, the lower the risk of developing a cardiovascular disease event. Higher the progression of CAC, the more likely people will develop CVD. Even the pericardial fat volume looks like it's maybe influential in those developing incident events, as well as fasting insulin. So stay tuned, this is very early data, not published, just wanted to give you a flavor of what's to come. So Masala has helped to influence some health policy guidelines. BMI is now, they use a lower BMI cut point of 23 to start screening for diabetes based on data in Asian Americans, including Masala. South Asians are now included in the AHA-ACC cholesterol guidelines as a risk enhancing factor. And I am a strong believer that you just don't reflexively start someone on statins based on having South Asian ethnicity. I think that the CAC can actually help to determine those who may actually benefit most from a statin, and you can wait on people with a lower 0 CAC score. We have normative data now on what CAC to expect in men and women. So some of the key lessons we've learned is South Asians have higher prevalence of cardiometabolic risk factors, and an adverse body composition may be partially culprit. And screen South Asians for risk factors regardless of their body mass index. Don't just, BMI is pretty much worthless if it's low. If it's high, we know that's something to work on in terms of lifestyle changes and getting people to lose weight, but don't be reassured falsely with a low BMI. I think the glass half full view of what we've learned in Masala is that there's several modifiable risk factors. There's so much we can do. And I think a prudent dietary pattern, healthy plant-based diet can reduce the risk of diabetes, one of the ultimate, most important risk factors, I think, for CVD. Exercise is very important. South Asians are getting the least amount of exercise of all the groups that we compared them to. And then moderation in the traditional cultural beliefs, using that integration bicultural strategy, because there's something that may be inducing more stress, or the behaviors that track with being very cultural may be adverse to health. I didn't show you our psychological data, but there's very strong associations with anxiety and stress with atherosclerosis, so risk reduction in that way as well. And then CAC progression, I think, is another fascinating area. And I think CAC is an important risk factor that we should recommend for anyone at intermediate risk. So where are we going in the future? Getting a little bit more deep in terms of our phenotyping. We have a grant from NIH to measure COVID, who's developed COVID in Masala. And we just got a long-term outcomes of COVID grant with many other cohorts to look at who develops long COVID and why, and how we can help reduce that risk. We're going to be doing whole genome sequencing. We're just starting to do a collaboration with a nonprofit company, and Dr. Amit Kara at Harvard is going to help us with the polygenic risk score analysis in Masala. So we'll be able to develop risk scores that are more South Asian based, since all of the ones that exist now are mostly in white populations. Our pilot, there's a new pilot study starting at Northwestern University by Dr. Nilay Shah, where we're bringing second generation, the adult children of our masala participants in to look at their health compared to other people from other immigrant groups, to look at whether South Asian adults who've been born and raised in the US have a lot of cardiovascular risk factors, or are they actually healthier based on that, what we're finding with the acculturation data in masala. We're hoping to join the Top Med Consortium through NHLBI, where we would have a lot more of this deep phenotyping with metabolomics, proteomics, transcriptomics happening, along with many other cohorts in the US. And we have a big grant pending to measure cognitive function in our South Asians as well. So we're looking forward to doing a lot more, hopefully for many years to come. And I do think one of the biggest, the most gratifying thing of being part of our big team is that we've been able to generate a lot more interest in South Asian health. And you can see people of every racial, ethnic background are new generation of investigators who are working on our data and writing papers and writing new grants and coming up with great new theories that they're testing. And I want you to go to our Masala study website. We update it all the time. All of our publications are posted. We have 80 publications from Masala so far. We're writing new papers every day, and we share our data with any researcher who wants to do a new analysis. We have a very transparent data sharing policy. And I want to thank all of our participants and our great colleagues and investigators and study staff at both sites for making all of this possible. It's a team effort. Thank you.
Thank you, Professor Kanaya, for coming on a weekday and giving us such insightful update on your landmark study. If you can hang around for 10-15 minutes, we have some questions, so I hope you can address some of them. Am I audible?
Yeah, absolutely.
Okay. So first question comes from our API president, Anupama. She's there, very quiet, very modest, but she's asking very good questions. She has also a lot of passion about South Asian heart disease. Her question is, do you recommend statin in somebody with a 0 calcium score? Some of the audience may not be a doc cardiologist. CAC means coronary artery calcium score. That's a new marker for atherosclerosis that is subclinical. So when we talk about CAC score, that's what we are talking. So the CAC score is 0.
Yeah.
Would you still recommend statin? Now, I know the AHA guidelines, but what is your take?
Yeah, no, so I mean, I think that that's a really good question. And we don't have the best risk model yet that would put CAC in as one of the risk factors. So I would want to know what their overall other risk factors are. So we could use the Framingham, the AHA pooled cohort risk equation for whites to see if they're intermediate risk or high risk. If they're intermediate or low risk on that score, which you can plug in, and they have a 0 CAC score, the other question I would ask is about family history. That's not captured in the Framingham or the pooled cohort equations. And I think family history is a really important thing for South Asians, especially to check. So if someone has no strong family history of premature coronary artery disease, and they have a CAC of 0 and they're low or intermediate risk, I think you can wait, and I would recheck CAC in 5 years and look at progression. And if that CAC has become all of a sudden high or has progressed a lot, then that's your time to start a CAC. And that's based on the best data we have, which is mostly observational. We don't have good randomized trial data on this question you asked.
Thank you.
Next question comes from Rajesh. Very, very good question, and I don't have any answer, but maybe you can highlight. So what is the difference between the South Asian that you studied here, who have come to America, versus the South Asians living in South Asian countries, especially in India?
Yeah. So we've been collaborating with the CARS study, which has 2 Indian sites, one in Chennai, one in New Delhi, and they have a Karachi site in Pakistan. And we've written 3 or 4 papers with them already, comparing diabetes, comparing chronic kidney disease, comparing other risk factors. And what we found was very interesting. We found that the diabetes rate of compared US South Asians in Masala to CARS was higher in India than it is in the Masala participants. That's the first time that any immigrant group in the diaspora countries have been found to have lower diabetes rates than in India. And this is just the canary in the coal mine, telling you the problem of diabetes in India is exploding. And we have more pre-diabetes in the South Asians here in the US, but in India, there's so much diabetes already that, maybe it's our lifestyle that we are engaging in more physical activity, eating more fruits and vegetables in our diet. The average number of fruits and vegetables eaten in the CAR study, Indians, is 2 per day, 2 to 3, and ours almost 4.5 to 5 in the South Asians in masala. There's big differences, and if anything, we're looking forward to more collaborations going forward, because the CARS is going to be measuring CAC in their South Asian groups in the near future, so we'll be able to compare American to Indian data directly.
So the next question comes, and which is a evolving question about the criteria for diabetes, pre-diabetes. Should we go by hemoglobin A1C? Should we go for GTT? And the line keeps going, prematurely earlier and earlier for South Asians.
Yep.
Now, what is your take on this? Should we be like more articles we read? They tell us that whether you're pre-diabetic or diabetic, the atherosclerosis starts much earlier.
Right.
So should we do more primordial preventive, go further?
Absolutely, absolutely. We need to start early. We need to be checking people's fasting glucose very early, like starting in teenage years. We need to be checking it routinely. There's a lot of obesity in our teenagers and early youth. We need to be very aggressive about prevention of diabetes with lifestyle change. Number 1, 2, 3, lifestyle change, stress reduction, improvements in physical activity. Then there are great medications too, but I am an internist. I don't jump to medications. I think there's a lot we can do with behavioral change. I do not think hemoglobin A1C is as good as fasting glucose. And that's because we have shown this with a paper we wrote with the CARS group. There's a lot more isolated elevated hemoglobin A1C in South Asians. So when we looked at our hemoglobin A1C data in masala, and we looked at our fasting glucose and our 2-hour glucose tolerance test data, there were a small group of people, about 3%, who had just isolated elevated hemoglobin A1C that would qualify them for diabetes, but fasting glucose was normal and 2-hour glucose tolerance test was normal. This is false positive. And I think just relying on the hemoglobin A1Cs alone without getting a fasting glucose that's high or a 2-hour glucose tolerance, you're going to overdiagnose people. And that's the same thing that they found in CARS as well. And that could be because of nutritional deficiencies. It could be that there's some differences in hemoglobin and breakdown of hemoglobin based on hemoglobinopathies. Don't know the exact reason why, but there is this falsely elevated. So don't rely only on hemoglobin A1C for screening. Use fasting glucose. If you are able to do a 2-hour glucose tolerance test, most patients hate it. Do it if they are willing to do it. But I don't go that far in my clinical practice. I just get the fasting glucose, but I get it almost yearly on most of my South Asian patients.
So I have one question. We see so much fatal heart attacks and aggressive, coronary disease, to the point that some people say is malignant, is diffuse, aggressive, and not very amenable to interventions that we do. Is it because of the change in the plaque? And what is this causing so much difference, even though most of the things are same between us and MASA study? Is it the rate of progression or that's something else is going on?
Yeah, I mean, we've shown that the rate of progression of CAC is much faster in men, in South Asian men in masala compared to all of the other men. So I do think that it's part of the problem could be the rate of progression of CAC, but I think there's so much more, like microvascular dysfunction. With all this diabetes, with all this insulin resistance, there's going to be more coronary microvascular dysfunction that you cannot measure with a CAC, right? And so in this new exam 3 that we're just about to start, we're going to be doing some adenosine echoes to try to look at coronary microvascular dysfunction in people who have HFpEF. And I think that that's part of the equation is there's something else going on that may be promoting more coronary disease and bigger, and not only big coronary arteries, but small coronaries.
So in the interest of time, I just want to last comment, which is coming from our president, Anupama, as well. how can API help you? We have such a large network of South Asian physicians, first generation, second generation. You're like the Birmingham, you're like the Bromward of South Asians. But Anupama, can you come on? Can you come and comment, Anupama, yourself?
Yeah, so this is a discussion between me and Dr. Brahma Sharma, and thank you so much for that very good talk. It's very interesting to know some of these facts, which are, this is a silent killer. Yeah, so we all know that. So I always, ask that, why Indians are more prone for, coronary artery disease. Why are people dying at young age, like in 30s and 40s? That's a biggest question. So your study, I was looking for some answer for that question, which I have, but I did not find the answer.
Yeah, well, wait another 5-10 years, maybe we'll get, you can't get an answer with 1,000 people in 10 years. Unfortunately, that's asking a little bit too much from very few people. And I think the criteria we used, for screening people to be in Masala, we took out the people with premature heart disease already, right? They had between age 40 and 84 and no existing cardiovascular disease. Right. So people who've already had their cardiovascular disease at age 30, 40, 45, 50, they're out of the study. But that doesn't mean we didn't have other people who may develop heart disease in their 40s that we should catch. So, but I think, it's not the perfect study in any way, shape, or form. We need more studies like Masala. We need Masala to be a 10,000 person study, not a 2,000 person study. And believe me, funding has been very difficult for this study, and to keep it funded has been my kind of every day, every night kind of, lots of gray hairs.
So thinking about how we can get the study more, more visible. How can we go 10,000 numbers in your study?
Yeah, the NIH.
We need to get the answer. We need to get the answer why 20s, 30s people are dying with coronary artery disease.
Yeah,
we have an audience. So Dr. Shobha Chokalingam wants to ask a question. Is it possible?
Oh, yeah, we have to unmute.
Dr. Shobha, go ahead, please. And
yes,
then
well, thank you, Dr. Kohli.
Yeah.
Well, thank you, both of you, and thanks for this very nice event today. I had two questions. It's about gender, Dr. Kohli. I don't know, as a male, you'll be happy later on, but I wanted to ask that question only because I really feel for the Indian men. They're developing this heart disease very young, as well as later on in their retired life. So I want to know, Masala study, wonderful Alkaji, if by any chance, were you able to quantify, like a pedometer, how many steps have they taken, and how really, are they sedentary? Are they helping their wives with household work? And, really, I know it's funny, but it also is important. Are they sitting, how many hours are they sitting in front of a computer? Because I would think they're also similar to Caucasian population, more well settled socioeconomically. But, physical activity, was there any way we could gauge that among the women who did not have that much of an increase, and in men who had quite a steep increase? Thank you, Dr. Kohli. In the interest of time, we'll have the expert.
Yeah. So we didn't have an objective measure of physical activity. It would be great to be able to add, accelerometers in Masala. We just didn't have the funding to do it. So we have questionnaires, and we ask people to honestly report what they're doing, and their physical activity levels were extremely low. Men were a little bit better than women. Women had even worse physical activity levels than men. So I don't think it's a lack of physical activity in, men versus women that explains it. Yeah.
That's
Dr.
great to know.
Chandrasekharan, you can go ahead with your next question.
Yeah, it was an absolutely excellent talk. My 2 cents is, it's a question, it's not a statement, is in India, they don't pay attention to their teeth. That's what I've, okay. So the airway and sleep disorder breathing has a very large effect on cardiac issues. And June, the American Heart Association released new guidelines for cardiologists to treat sleep disordered breathing. The second thing is that, the liver you mentioned in your talk about fatty liver and so forth, that's all associated with sleep and breathing. On the sleep boards and things, they're asking about fatty liver disease.
Yep.
So, I think that's a component. And lastly, in India, psychiatry, a lot of people don't pay attention to it, but there's a big underlying sleep and breathing issue under psychiatry as well. So,
yes, absolutely.
So these may be confounding factors for your
Yeah.
study. And last quick thing is everything is headed toward genetics.
Yeah.
Your study seems great, but my only question is, why are you referring to Indians as South Asians? Because with such a large population, why are we not referred from it? This is nothing political, just a genetic question. Why aren't we referring ourselves as Indians?
Okay, so lots of questions there. So yes, I'm a big believer in sleep apnea being possibly an independent risk factor. We actually looked at sleep apnea scores using a questionnaire measure. What's the scale? I'm forgetting the name, but there's a questionnaire we use to measure how much sleep apnea someone had. And it was an independent risk factor for CAC. More than the traditional, diabetes, hypertension, age, and smoking, and cholesterol. So having sleep apnea high score on this Epworth, was it Epworth? I'm sorry, I'm forgetting the name of the scale now, but that was an independent risk factor for those who had higher levels of CAC. So I do think that there will be something there with sleep apnea in the long term. In terms of why are we calling it, why are we saying South Asians? We wanted to be inclusive when we started Masala, and include all South Asian groups, people who self-identify from any of the South Asian countries. But as we've gone down that road, we realize that there's big differences in risk factors, social risk factors, as well as behavioral. And so that's why we're increasing the size of the Pakistani and Bangladeshi populations. Indians, we have 906 Indians in Masala now, and we only have 67 Pakistanis, and we have 6 Bangladeshis. That's atrocious. So to be able to say anything about these 3 groups independently, we need, at least 600, 900. So that's why we have this new grant to actually add more Pakistanis and Bangladeshis. We're going to be recruiting them from New York City and Chicago. So we look forward to having data to actually compare, because the places that have been able to compare Bangladeshis, Pakistanis, and Indians found, guess what? Indians have the lowest risk of cardiovascular disease. The highest risk is in Bangladeshis. The second highest risk is in Pakistanis. The third highest risk is in Indians. So I think we're going to find the same patterns here if we had enough numbers. And so why is that? Why is it that Bangladeshis have much higher risk of developing premature coronary disease than Indians? We won't know that until we have good enough numbers. And I don't think, maybe we won't know that even with 600, we'll need to get to 6,000 Bangladeshis and 6,000 Indians to know that. So I think these are very exciting questions, because we can't lump everybody together as South Asians. And when we do the genetic stuff, we'll be able to more refine the genetic ancestry of people to look at, are there genes? Are there, there isn't going to be one mutated gene that is causing premature heart disease, because that would have been found 20 years ago. No, I think it's going to be a polygenic type of risk that we see that people, are born with, that they come into the world having high risk. But I don't think gene is destiny, and we can do so much to change our genetic risk. And so that's what's exciting to me, is let's figure out the behavioral risk factors, the lifestyle risk factors, the cultural risk factors, and let's modify those to prevent cardiovascular.
One last question from the audience is from my neighbor, Dr. Prajapati, he's a cardiologist. What about enrolling and including yoga, meditation, or a traditional avenue into a holistic approach? Because there are some data showing outcome effect.
Yeah, no, so I did a whole trial on yoga, and we did it in pre-diabetic individuals who were overweight and sedentary, and we found that yoga was associated with a 6 milligram per deciliter drop in blood glucose levels in the pre-diabetes, which is exactly what the diabetes prevention program found in terms of reducing risk of diabetes with lifestyle change. So I'm a big believer. We actually ask about yoga in the Masala study and quantify how many minutes of yoga people do in their week. We haven't found any strong associations with any cardiometabolic risk, though, based on those data. But we'll keep looking.
Dr. Brahma, do you have any parting comments or any other comments you'd like to make before?
I think let's close. And again, Api is with you. I can speak on behalf of the leadership there. Heart disease is right front and the center. And literally, it is very close to our heart. We hear news items from India, and here young people are dying right and left. And I thank the Api leadership for putting me in the spot and taking the leadership for the last 2 years and many more years to continue to make this our prime target campaign and mission. We are working on both ends, prevention, early detection, as well as we're also working on the other side also, CPR, and home CPR. Anupama is a very big advocate of that. So we are working, but at the same time, we like to work with you, Professor Kenya from the API, if you can, enroll, participate, go to Congress and work with DEPAL to get more money, because this is our life issue. Our race is race against time.
Absolutely. So, absolutely. If you know, because right now the only new participants we're enrolling are from New York and Chicago, Bangladeshis and Pakistanis. So we'd love to enroll some more people into Masala who are Bangladeshi and Pakistani to, have enough data in these groups. So that's something that we're starting in November. So, you guys are from mostly Pittsburgh or the East Coast, and
we're all over the country.
All over the country, and some are from overseas, by the way. Some of the
wonderful. Okay.
Overseas, South Asians.
Wonderful. Great. Well, I'm also happy to give more of these talks to different APIO type of organizations, because I don't think our Indian physicians in the US know this data, and that's sad. They need to know what we're learning. And
I think
thank you, Dr. Kanaya, for that offer. We will take up on that, and probably will invite you for next year.
And please also invite my co-PI, Dr. Kandula. She's more than happy to give these talks as well.
She's in our list. She's in our list.
Wonderful.
Also an API
we'll share the
family.
Yeah.
And we'll have. Go ahead, Anupama. You want to give it?
Dr. Kandula is here. Namrata? I don't think so, right? Yeah.
So anyway, thank you so much, Dr. Kanaya. It's a really illuminating talk, and we are touching the tip of the iceberg, like you said. We need a lot more research, and we also can come up with more preventive strategies, like many of Indian traditions, like yoga, meditation, mindfulness, and proper diet, and all those things, and also exercise. And we'll invite you again for next year for World Star Heart Day. Please mark your calendar, and maybe have a panel discussion, and we'll announce it widely again and get more people to join, because this is a life-saving self-care thing we need to do for our physicians. And again, want to thank all the members who are here and late in tonight on the West Coast, and East Coast. And thank you again. And Dr. Anupama, if you want to say a final comment, we'll conclude.
Thank you. I want to thank, truthfully, I want to thank Dr. Kanaya for coming and, giving us this very enlightening topic, actually. And I think it's much needed for our physicians, and also through our physicians, I think we need to reach to our patients also. So let's see how API can support this project, and I'm really into it. Yeah. Thank you. Thank you so much.
Thank you. Good night.
Good night, everyone.
Thanks,
Bye.
Dr. Sharma, for